clinical inertia is widespread in sexual medicine practice also. There is a significant delay in diagnosing and treating various sexual health issues because of the stigma associated with sexual health problems, in addition to the other usual causes that is seen in other common diseases like diabetes, hypertension, etc. A very good evening to all. First of all, I would like to thank the organizers for giving me an opportunity, and thank you, Chairperson, for the nice words of introduction. I'll be briefly dealing about the clinical inertia. I'll be talking under the following heading: general aspects of clinical inertia, then role of clinical inertia in sexual medicine practice, and how to tackle clinical inertia. As we all know, clinical inertia is the inability or failure of the healthcare provider to initiate or intensify therapy when it is clinically indicated. So, in simple words, it is an evidence-practice gap. And evidence-practice gap is defined as the difference between what we know from the best available research evidence and what actually happens in the current practice. So it is the gap between the best practice recommendation and the level of care the patient received. So in simple words, clinical inertia is the recognition of the problem but failure to act. But in people with suboptimal disease control, if we are adding one agent which is unlikely to achieve the treatment target, then that also contributes to clinical inertia, even though we are increasing the dose of medicine or adding some therapy. For example, in people with diabetes, suppose if the HbA1c is 10, we know that simple metformin alone cannot bring down HbA1c from 10 to 7 or the expected target level. And if we are adding only metformin, we can say that we started treatment. But that also contributes to clinical inertia because the medicine which we added, it is not capable to bring the HbA1c level to the target level. So in simple words, we can say that recognition of the problem but failure to act appropriately also contribute to clinical inertia. The term clinical inertia was first coined by Phillips et al. In 2001, and there are various terms like therapeutic inertia, physician inertia, diagnostic inertia. These are all synonymously used with clinical inertia. But strictly speaking, these are all the subdivisions of clinical inertia. I will come to that later. So what is diagnostic inertia? Diagnostic inertia is defined as the failure to consider diagnosis when it really exists. And therapeutic inertia is the failure of the provider to begin new medication or increase the dose of the existing medication when an abnormal clinical parameter is recorded. Similarly, in a patient with suppose diabetic patients with other comorbidities, hypoglycemic potential, chronic kidney disease, the usual target is 7 or 6.5, but such patients, if we keep the target in the normal range, they may go into recurrent episodes of hypoglycemia. So in such patients, we have to increase the target. So we have to consider the treatment target subjectively, and we have to reduce the treatment dose if patient is developing recurrent hypoglycemia. So in patients with such condition, if we fail to reduce the treatment dose or the drug therapy, that also constitutes clinical inertia. So clinical inertia also apply to the failure of the physician to stop or reduce therapy which is no longer required, and that is called reverse clinical inertia. The classical example is failure to de-intensify therapy in frail diabetic phenotypes, those who are having elderly or underweight diabetics, or those who are having long duration of diabetes, those who are having underlying heart disease or stroke with diabetes, or those diabetic people with renal insufficiency who are more prone to develop complications. So this is our own paper. We coined a term therapeutic dragging, which means that it's a type of therapeutic inertia where there is intensification or escalation of treatment when the therapeutic target is not achieved, but it is inadequate and insufficient to achieve the therapeutic target, and there is no further intensification in the stipulated time period. So, in simple words, it is the recognition of the problem but inadequate action. That is called therapeutic dragging. So, clinical inertia we can divide into preventive inertia, diagnostic inertia, and therapeutic inertia. The inertia in prevention of development of risk factors or the disease is called preventive inertia. It can be either primary, secondary, or tertiary level prevention inertia. And diagnostic inertia is inertia in considering the diagnosis, or it can be inertia in assessing the disease control, and it can be inertia in diagnosing the disease complication or drug-induced problems. Coming to therapeutic inertia can be inertia in the initiation of the treatment, or inertia in the intensification of treatment, or inertia in de-escalation or de-intensification of the treatment when it is required. So, inertia in intensification of treatment can be of two types. There is no intensification which comes under therapeutic inertia, and another subdivision of therapeutic inertia where there is intensification but which is inadequate, and that is called therapeutic dragging. So, inappropriate treatment outcome can be due to various reasons. In those not achieved treatment target, it can be due to inappropriate escalation or de-escalation of treatment, that is called clinical inertia. Or if there is appropriate escalation or de-escalation of treatment and still there is inappropriate treatment outcome, it can be due to disease characteristics like resistant disease or associated comorbidities or drug resistance or non-adherence. And those achieved treatment target, if there is inappropriate treatment outcome, it can be due to other unidentified risk factors or genetic factors. So, we propose a diagnosis or classification criteria for classifying therapeutic inertia. So, the components are therapeutic action inertia. There is undue delay in initiation or escalation or de-escalation of treatment, and the duration criteria, there should be a defined time period which is particular for the particular disease. For example, if we are considering diabetes, every 3 to 4 months we are doing HbA1c. So, the 3 to 4 months, if there is no escalation or de-escalation of therapy, it comes under clinical inertia. But in case of myocardial infarction or stroke, where we have to act immediately, even delay in minutes or hours constitute clinical inertia. Coming to therapeutic inertia outcome criteria, there should be a failure to attain the therapeutic target which cause progression of the disease or development of complication or development of drug-related complications or over-treatment related complications, which is an example of reverse clinical inertia. So, the therapeutic gold standard criteria, there is a well-established treatment guideline and therapeutic target, and there should be a clear evidence of benefit of therapy. Then only we can say that if we are not achieving the target, there is clinical inertia. And the basic requirement is that the mentioned treatment facilities available, accessible, and acceptable and affordable to that particular society. And the exclusion criteria is if the therapeutic target is relaxed in view of patient's profile or associated comorbidities or disease condition, we cannot consider that as clinical inertia. For example, in diabetic patients with recurrent hypoglycemia, old age, or chronic kidney disease, the relaxation of the treatment target, that is HbA1c level, that will not come under clinical inertia. Coming to clinical inertia in sexual medicine practice, clinical inertia is widespread in sexual medicine practice also. There is a significant delay in diagnosing and treating various sexual health issues because of the stigma associated with sexual health problems, in addition to the other usual causes that is seen in other common diseases like diabetes, hypertension, etc. So, clinical inertia can be preventive, diagnostic, or therapeutic inertia. Preventive inertia is the inertia in preventing the development and progression of sexual dysfunction in sexual medicine practice. The classical example is atherosclerotic vascular disease related erectile dysfunction. We know that there is development of risk factors first, then development of lifestyle disorders like diabetes, hypertension, dyslipidemia, then development of complications like atherosclerosis, vascular obstruction leading to erectile dysfunction. So, this stage if we interfere, we can prevent the development of erectile dysfunction. So if we fail to interfere at these stages, it is a classical example of clinical inertia in the prevention of erectile dysfunction. Similarly, various childhood sexual abuse and sexual trauma can cause sexual dysfunction. So social and legal strategies to prevent sexual abuse and sexual trauma help to prevent the development of various sexual dysfunction, and our inertia in implementing these can lead to various sexual dysfunction, and this is an example of inertia in the community level. Coming to diagnostic inertia is also prevalent in sexual medicine practice. Diagnostic inertia is considered when the diagnosis exists, but we are not considering or giving importance to that diagnosis. In people with sexual dysfunction, they are usually reluctant to disclose the issues, and they use various vague terminologies to explain their sexual health issues, and most of the time healthcare providers will not be able to pick up what they actually mean, and even if they disclose also, healthcare providers are also reluctant to address the sexual health issues, and most of the time they will be giving some multivitamins or some placebo drugs in order to buy time. This is a classical example of diagnostic inertia which lead to treatment inertia. So therapeutic inertia in initiating treatment of various sexual health issues is very common. As I told, even if the patient comes with sexual health issues, most of the time we will be prescribing antioxidants or multivitamin rather than offering specific therapy for the sexual health issues. This is not mainly about the sexual medicine practitioners. When the patient goes to other specialty, this is what happens usually. And in addition to that, another stage is inertia in addressing the comorbidities and complications. The classical example is in patients with atherosclerotic vascular disease associated erectile dysfunction. If we are treating only erectile dysfunction without addressing the cardiovascular risk factors, as we all know that patients with atherosclerotic ED can develop cardiovascular events in the next 3 to 5 years after the onset of ED. So if we are not evaluating for the cardiovascular events and not taking proper care, patients will land up with acute myocardial infarction within a few years. So this is a classical example of inertia in addressing comorbidities and complications. So this is the diagrammatic representation of the same stages of consultation and factors contributing to clinical inertia. Recognition of the sexual health issues by the patient. Most of the patients think that the sexual health issues are the part of aging, and majority of them are not seeking medical help. And if they decide to consult sexual health personnel, there are a lot of stigma associated with sexual health problem, and there are false beliefs that there is no effective treatment for sexual dysfunction. This prevents the patient from approaching sexual health practitioners. And even if they consult with practitioners, patients use vague terms, and healthcare professionals are reluctant to address, and healthcare professionals' attitude towards sexual health problems and their knowledge and experience in the management of sexual health issues also matters. As we know, sexual health problems are not included in the academic curriculum of undergraduate medical curriculum. So majority of the doctors are not officially trained in sexual medicine or sexual health issues. And coming to the treatment of sexual dysfunction, lack of proper referral systems and specialist care, cost of therapy, failure to identify and control the risk factors and comorbidities. All these contribute to clinical inertia, and during follow-up, people think that one-time therapy is the solution for sexual health problems, and there are failure to control risk factors and comorbidities. So factors contributing clinical inertia can be divided into physician or provider related, patient related, and system related. There are a lot of factors contributing. We will be mainly enumerating important ones. Patient related factors include the stigma associated with sexual health issues, embarrassment, discomfort in in discussing sexual health issues. Healthcare provider related embarrassment to discuss sexual health issues, lack of proper training about the sexual health issues in the medical curriculum, lack of confidence and lack of time and busy OPD, lack of support, lack of availability of multidisciplinary team care and specialist care, and providers' inability to provide appropriate care. Patients' characteristics include patients which again contribute to clinical inertia from physician side include if the patient is having multiple comorbidities like those who are having coronary artery disease or heart failure, even if they say some sexual health issues, we are reluctant to treat because we are afraid about the cardiac condition, whether it may get aggravated. And if the patient is on multiple drugs, we are again afraid to treat properly because we may be thinking about the drug interactions and all. And the quality of the relation between the patient and healthcare provider, concern about the adverse reaction or drug interaction, health literacy, affordability and socio-economical status of the patient, patient's attitude and preference, non-adherence to treatment, all these influence the healthcare provider while taking appropriate decision. And the system-related factors include time concerns, inconsistencies between guidelines, poor planning, communication among the healthcare teams, resource constraints, and lack of team approach and decision support system. So the various factors like physician or provider related, patient related, and system related are not isolated compartments. They are interrelated and overlapping. So this is again the diagrammatic representation, physician's inertia, patient's inertia, physician's inertia, system inertia. All these contribute to clinical inertia. And this is not an isolated compartment. There is considerable overlap between patient inertia, physician inertia, and system inertia. And similarly, preventive inertia, diagnostic inertia, and therapeutic inertia. Suppose, for example, if in a diabetic patient with erectile dysfunction, if we are treating diabetes and risk factor properly and avoiding the development of atherosclerosis complications and erectile dysfunction, it's and if we fail in that, it is an example of preventive inertia in the development of erectile dysfunction. But if we are not treating diabetes and complication properly, it is a therapeutic inertia if we are considering the treatment of diabetes. So it can be overlapping and it can be the same situation can be either preventive inertia or therapeutic inertia if you consider different scenarios. So how to tackle clinical inertia? Clinical inertia results in improper evaluation and treatment of patients leading to failure to achieve treatment targets, and there is poor control of the disease process and increased risk of disease associated complications. So patient inertia, physician inertia, and system inertia contribute to clinical inertia. And it leads to poor control of the disease, increased morbidity and mortality, and increased risk of complications. So how to tackle this? There are, I'm enumerating only important one, improving the awareness regarding clinical inertia among healthcare professionals, ongoing medical education and training programs, coordination between primary, secondary, and tertiary care, adapting current practice guidelines, and self-evaluation of performance by healthcare professionals is very important in self-improvement. And use of computer-based decision support system, patient education program, improved communication, increased direct patient contact time, and improvement in the system infrastructure and multidisciplinary team approach. All these helps to overcome clinical inertia. And in sexual medicine practice, improving awareness regarding the sexual health problems in the public, educating the importance of treatment of sexual health problems, and training regarding the management of various sexual health issues to the healthcare professionals, and ensuring privacy for the patient with sexual health issues. All these help to improve clinical inertia. So the take-home message is clinical inertia delays or even denies the best available treatment for the needy patient. Clinical inertia exists in all aspects of sexual medicine practice, and identifying the factors contributing to clinical inertia and tackling it help to improve the patient outcome. Thank you for the patient listening.
Thank you, Dr. Raveendran, for awakening all of us from the stage of inertia. And here afterwards, we'll promise you to be very swift in our action. Thank you very much.
Thank you, sir.
Thank you, sir, for such a wonderful presentation. Now I request Dr. Paras and Dr. Murugan, sir, to kindly felicitate Dr. Raveendran, sir. Please bring the memento.
Thank you.
innovative and
Thank you, sir.
new one.
Thank you, sir.